Yeah, so we shall straight away go to the cases. So this is the first vignette that we will be getting in the case. My screen is visible, right? Okay. So this is and you need to, and I cannot go back to the Zoom chat box and see, right? So you just unmute, one of you unmute yourself and read out the scenario. So this is the first poster people place in the exam. Also, you get this small 4-5 line vignette followed by initial blood gas reports as well as some blood test reports. And the colored, that is the red colored ones are the abnormal reports, which will be same in the exam. So in the exam, you don't have to go look for the abnormal reports. It will already mark in red because it's a very time sensitive exam. Okay, so do not to make it easy. It will be like that only. Like the real exam.
Sir, your voice is not clear. It's not audible.
So why don't you just read out the scenario, and after that we can go to the next question. You will get around 10 minutes. So do not take 10 minutes. Just read it out a bit fast, and we can face the next questions. Remember that every line is important. Okay, so just because the time is less, you cannot just jump past the lines. I'm giving you some time to read the scenario and the blood test reports. It's 5:48 right now. And no 5 minutes. We can take up the case at 5:53. Everybody go through the scenario. Otherwise, it will be like a theoretical discussion. That is not what we want to edit. So this is 5:52. So one of you unmute yourself and tell me what is the case. Agree. But this will be an interactive session. Otherwise, like it's very difficult to proceed. Any of you just unmute and tell me what you read about the case.
Sir, this is a male patient with 73 years old male patient, possibly obese patient, presenting with post-op. He's a post-op case of abdominal aortic aneurysm repair. Presenting with hypoxemia, perhaps because FiO2 is 0.4 and PaO2 is 91, saturation 98% on FiO2 of 0.4. And this patient is also developing norepinephrine requirement, possibly because of ongoing sepsis, and urine output is low because of AKI setting in because of 3 hours clamp of the right renal artery. ABG is showing high in iron gap metabolic acidosis with hypoxemia, with elevated lactates and low SCBO2. TLC is high, 20,000 counts, with hyperkalemia and hyperkalemia setting in, and urea and creatinine are elevated, suggesting of acute kidney injury, and troponins are high, and serum CK levels are also elevated.
So this is what you have to note down during the first 20 around 20 minutes that we will get for the first case. So whatever you think is important, you have to note it down. You have to calculate you have to interpret the EBG, calculate the like with the metabolic acidosis, you have to calculate whether it is high iron gap, normal iron gap. You have to look for any compensations. This is the usual ECG EBG interpretation. And you have to also look out for the blood value that have been given, whether there is any hyperkalemia, whether any AKI, whether there is any features of myoglobinuria, any features of cardiac enzyme swing rates, any features of DIC, low platelets, sepsis, blood loss, these type of things. So we have to, so basically in the other part, that is the CCS, and that is the X-ray posting. That's a very rapid part of the exam. The day you will get that part. So there you do not need a paper, pen, etc. But in this long test, short test type, you need a paper and a pen or a pencil, and you have to show it to the examiner beforehand. That will hand it. Otherwise, they will not allow you later. Remember it. Do not forget to take the paper and the pen before the exam, because the proctor, they will look what you do. And then you have to also show that you have this blank paper and the pencil and the pen, and you will note something down during the case. They will allow it. But just remember to show it to them. That is one thing. Secondly, use the paper and the pen and those initial 15-20 minutes to note down these topics, whatever you feel is right. For example, here, as I actually pointed out, there is an issue of post-surgical case. Receive lots of massive blood transfusions. So the case may go towards the massive blood transfusion, the hypothermia, and the metabolic acidosis coagulopathy part. The third point is there is an acute kidney injury setting in, so it can move toward the CRT or the hemodialysis part and API part, and there is also a shock component. So shock they can move anywhere. It can be cardiogenic shock, it can be septic shock, it can be hypothalamic shock. So these are, and there is a then they are mentioned that they have that the patient has received 700 minutes of intrathecal morphine, and their right arterial was planned for a long time. So right arterial can for a long time, that may lead to ATM, and that can lead to some sort of other problems. So, and there are multiple past medical history problems. Remember that once the 15-20 minutes is over, you cannot get back to this site, to this site. So note everything now that is there. Do not know what is found important later on. Suppose the last they ask you about the very difficulty. There you can tell that yes, the patient had a coronary artery disease, the patient is obese, these things. There after 4 digit deaths, you may not remember the weight of the patient. I mean, you will definitely not remember the weight of the patient if you don't know it down. So note these things down. That is why this 15-20 minutes is very important. And this will determine whether you pass this case or not the other class. Okay. So thank you, doctor, for pointing out these things. And now we move to the real questions.
Sir, your voice is not clear. We are not able to hear.
Yes, sir. Is the problem there for everybody?
Yes, sir.
Okay, because I can hear your voice very clearly. So just a minute.
Now is it clear?
Yes, sir. Much better. Yes.
Okay. So what I was telling was that this is a post-surgical case, right? So when you note these things down, you have to note everything down on a piece of paper, and you will need to show this piece of paper to the examiner. That is the proctor who will see your room and your the examination site and the surroundings before the exam starts. If you do not show that piece of paper, they will not allow you later. So you need to remember that firstly. Secondly, once you get this 15-20 minutes to read this case, then note everything down. Like here, there is a post-op case, massive blood transfusions, there is multiple comorbidities, and the intra-op there were two significant. One thing was this right renal artery prolonged clamping. Second one was 700 mics intrathecal morphine. Another thing was that that he is now going into shock, and he has developed low urine output and urea creatinine is raised. And the important blood groups which are typed also noted down: the high metabolic acidosis, high lactate, high glucose, SCVO2 is low, and high total count. Because once the 15-20 minutes is over and you move to this question part, they will not go back. So once this site appears, you cannot again go back to this slide. Okay. So if you do not remember something, then they will not tell you. Do not expect, they will not help you anyway. They will be very cooperative and friendly and everything, but they will not go back to this slide. So this slide will determine, so this 15-20 minutes will determine how you perform the long case of EDIC part 2. That is why this was very important. So now they have asked active issues at this point of time, and they are expecting a very to the point answer. 4 or 5 points. Maybe this question has got 3 points, and they have marked it as 1-1-1 or 2-1-1, so 4 marks. If you tell those 3 points, they will give you the 4 marks. If you tell 5 points and suppose you miss one of their points, then they will give you 2 marks. They will subtract the marks of the other point. So better is to list down all the active issues. So I don't think you have written down. So I am going back, but they will not go back to this slide. So tell me the active issues at this point of time.
High in iron gap metabolic acidosis, hypoxemia, hypotension and shock, hyperkalemia, acute kidney injury, and elevated CK levels, troponins are high,
Okay.
hyperglycemia.
Okay. Yeah. So this is the way to answer. Tell them everything that you have found out in active issues, because usually the first question will always be an active issues, or it will be a summarize your case. If they will summarize your case, then I think it will be easier, because then nobody will miss much. But active issues, the main problem is that many of us, even me also, when I started preparing, and other participants, my friends who have given the exam this time, what they did was they told the active issue that they usually think like in an ICU. That is, firstly, they told something like septic shock, not mention septic shock. You do not know whether it is septic shock or not, firstly. Second was AKI, and third was handling the metabolic acidosis. And then they stopped. But suppose the answer was, one of them was, answer was hyperkalemia. They give very much importance to hyperkalemia, okay? So if the potassium level is high, 5.5, they are mentioning 5.3 as normal. So even if it is 5.5, and it is in red, that means it is also abnormal. Always mention hyperkalemia, because that will 99% of cases that will be one of the active issues at this point of time.